Good morning, everyone. And I am Mary Quay, the Associate Commissioner of Market Regulation and Professional Licensing here at the MIA. And I am happy to welcome you today to our fourth meeting of the work group for Senate Bill 460. In today's meeting, we will hear a presentation on the New York CHAP program, which has been discussed as a model, from Stephanie Campbell, Director of the New York State Behavioral Health Ombudsman Office, and from Tricia Allen and Greg Meyer of the New York State Office of Addiction Services and Supports. The work group will then continue its review of the CHAP bill, starting with a discussion of the structure, legal status, and accountability of the program contemplated by the CHAP bill, including the responsibilities of the incubator and hub entities. And first, I want to announce who's here from the MIA. We have Kathleen Borain, the Insurance Commissioner. David Cooney, Associate Commissioner of Life and Health.
Morning.
Joy Hatchett, Associate Commissioner of the Consumer Education and Advocacy Unit.
Hello, everyone.
Van Dorsey, our Principal Counsel.
Morning.
Craig I, our Communications Director.
Hello and welcome.
And we have two new members of the MIA, Jamie Sexton.
Hello, everyone.
And Andrew Tress.
Morning.
And do you want to give your titles?
Sure. You can go ahead, Jamie.
Sure, absolutely. Hello, everyone. I am the new Director of Health Insurance Regulatory Affairs. I'm looking forward to working with all of you on this and other issues.
And I am the Director of Government Relations. Also happy to be a part of this group, and nice to meet everybody.
Okay, thank you. And can the other work group members please introduce yourselves? I see Quentin Askew.
Good morning, everyone. Apologies for technical issues, but Quentin Askew, President and CEO with 211 Maryland.
And Delegate Cullison.
Good morning, everyone. Thank you, Mary. Bonnie Cullison, representing District 19 in Montgomery County, and Chair of the Insurance and Pharmaceutical Subcommittee.
Thank you. Neil Karkanis.
Hey, good morning. Neil Karkanis here on behalf of the League of Life and Health Insurers. Welcome aboard, Andrew and Jamie.
I see Ann Seacott.
Good morning, everybody. Ann Seacott with Public Policy Partners, representing the National Council on Alcoholism and Drug Dependence in Maryland.
Josh Howe.
Good morning, everybody. Josh Howe with Compass Government Relations, representing the National Alliance on Mental Illness.
Pat O'Connor.
Good morning. I'm Pat O'Connor, Deputy Director of the Attorney General's Health Education Advocacy Unit.
Kim Camarada.
Good morning, Kim Camarada, the Director of the Attorney General's Health Education Advocacy Unit.
Allison Taylor.
Hey, good morning. Allison Taylor, representing Kaiser Permanente.
Deb Rifkin.
Good morning, everybody. This is Debbie Rivkin. I'm with Care First Blue Cross Blue Shield. I apologize that you don't get to see my smiling face today, but I am driving. So that's why I'm here, but you won't see me.
Okay, I have been going off who I can see on my screen. So anyone I overlooked, I apologize, but please speak up now. Oh, Ellen.
Yep. Good morning, everyone. I'm Ellen Weber. I'm with the Legal Action Center, and we convened the Maryland Parity Coalition.
Okay, anyone else? Okay, and thank you.
Mary, I see someone from Delegate Lewis's office.
Okay.
They indicated in the chat that they're having some technical issues.
Okay.
The delegate will be on in a minute. I don't think I've seen her come in yet.
Well, we can give that a minute then. I'm sorry people are having problems.
I'll tell you what, I think, because I came on a few minutes ago, maybe we can separately see if we can
Okay.
assist them. Craig, if you want to maybe reach out and see if there's
Yeah,
any help that you
I
can
believe from
give.
Delegate Lewis was in the attendees, and I just promoted her to panelist.
Okay,
So
that's great. That's great. Okay. So she come in, it's like she,
yeah, let's see.
there we go.
Oh, okay, I see her.
Thanks for catching that, Joy.
Okay, good morning, Delegate Lewis. Okay, well, thank you. And now we will move on to the presentation on the New York CHAP program. And Van, do you want to make introductions?
Sure, I'd be happy to. Over the last several weeks, Betty Diener and I of my office have been fortunate enough to have several conversations with Stephanie Campbell, who is the director of the Office of Behavioral Health Ombudsman Program, and her colleagues about what it is New York is doing up there, how their program is structured. And quite frankly, we thought it would be very useful for the task force to hear directly from Stephanie and her crew, rather than from me. I think it's probably much more interesting to hear from her. So Stephanie, without any further ado, I'm going to give you the floor.
Great, thank you so much, Van and Betty. It's been wonderful having conversations with you and the folks over the last few weeks. As well as just to express my gratitude for being welcomed into this space to talk to you a little bit about what we're doing here in New York State with the New York State Behavioral Health Ombudsman Office. I also want to acknowledge and thank Ellen Weber for the incredible work that she has been doing for decades on the issue of parity and advocacy for individuals impacted by substance use and mental health. So thank you so much, Ellen, for being here and the valuable work that you do. I think the slide deck is going to be shared. Okay, great. Thank you so much. So if we could go to the next slide, please. So, we saw here in New York the need for the program that we in government, we love acronyms, so we named it CHAP, and I'll say a little bit about that in a moment. But there was a lot of groundwork that led up to the creation of the first in the nation Office of the Independent Substance Use Disorder and Mental Health Ombudsman Program, also known as CHAP, which was enacted in the 2018 executive budget by the former governor and the legislature to create a program that we now call the Community Health Access to Addiction and Mental Health Care Project. That's the acronym CHAMP, for the purpose of assisting folks that have a substance use or mental health condition with using their health insurance, accessing their benefits, and then to also help to identify, investigate, refer, and resolve complaints that are being made by or on behalf of consumers regarding their coverage, and also to help folks access care. And I'll talk a little bit more about how that component has really morphed into the project. But the program was charged with helping also providers who are having difficulty resolving their insurance problems around the clients that they serve. And so, in addition to addressing specific insurance barriers, the team on CHAMP assists New Yorkers to gain access to inpatient, outpatient services, residential services, including medication and other social determinant of health needs, which also include transportation, housing, and recovery support services, including peer services. Next slide, please. The structure of the program is that there's a master contract that was issued. The funding comes through the Office of Addiction Services and Supports that had been allocated through the executive and legislature. And that master contract goes to CSS, which is Community Service Society. And they have set up a helpline, which is 888-614-5400, that folks are able to call into and begin opening a case with our team on some of the issues that I had discussed. CSS also provides a learning community for the entire CHAMP team. And I'll talk a little bit about that in just a little while, and also manages, under my support contracts, budgets, and then collect invoices for billing purposes. CSS is also tasked with ensuring that quality assurance is being utilized in performance evaluation and monitoring the program. I also have ongoing conversations, as well as other colleagues of mine at the Office of Addiction Services and Supports, Office of Mental Health, as well as the Department of Financial Services and Department of Health. And we issue reports with CSS to the state on some of the Sentinel issues that are being reported through the case, aggregated case data that comes into Salesforce, which is the CRM data collection. And then we have the CHAMP specialists, which again, our invaluable partner Legal Action Center has been a major part of our team, as well as Medicare Rights Center, also a nationally recognized advocacy and education and training for all things pertaining to Medicare, and the New York State Council for Community Behavioral Health Care. That is a 30+ year organization that's been doing advocacy and represents providers of both substance use and mental health care here in New York State. And those specialists provide technical assistance. They do training for our monthly meetings, as well as our 2-day intensive trainings. And they help us with complex cases that come in through the helpline. And then the other spoke of the wheel is our CHAMP CBOs, our community-based organizations that exist around the state. And these are well-established local community organizations that provide support and take individual cases and do outreach to their communities and provide connections to resources and help with referrals in their communities. And those 5 current CBOs are Adirondack Health Institute in the north part of the state, the Community Health Action for Staten Island out on in New York City on Staten Island, Family and Children's Association out on Long Island, the Family and Children's Counseling Services in Central New York, and Save the Michaels of the World, which is out in Western New York. Next slide, please. I mentioned just a couple of minutes ago that each case that comes in through the helpline, a case is opened up, each call, and that data begins to be entered into Salesforce and is aggregated and tracked along the course of contact with that individual. And also, I'm also collecting data in my office of complex cases that come through through my office. And so individualized assistance is provided through a coalition of regional community-based recovery organizations that I mentioned, those CBOs, those 5 CBOs, as well as the technical assistance that I mentioned from Legal Action Center, the council, as we refer to them, the Medicare Rights Center. And then we have the helpline, which is a statewide helpline staffed by attorneys and social workers who are managed and staffed by Community Service Society. And then in conjunction with helping each person who calls with either providing them with information or helping them resolve negative determinations for claims, or helping them access other benefits, insurance benefits, even helping them enroll in a more appropriate plan if that's needed. All of that information is collected, and then we aggregate that in monthly, quarterly, and annual reports that inform our state partners working on addressing parity and access to care issues. Next slide, please.
Hey, Stephanie, for those of you who, for those of us who aren't as familiar with New York as you are, could you explain what the Community Services Society is?
Sure. So Community Service Society is an organization that's been around over 100 years, and they have been working very hard on advocating for vulnerable populations. They also, they're based in New York City, and they, have been given also a contract through DOH and multiple other contracts. But one of the reason why we thought that they would be an appropriate partner to help with this is that they have an established track record for running other programs to help folks access healthcare. And they also enroll people onto the exchange through the Affordable Care Act. And so we determined that given their track record, and also given their partnership with some of our other specialists, that they would be an appropriate entity to contract with to do this hub and spokes model. Does that answer your question, Van?
Yes, thanks for the interruption.
Sure, no problem. So just in a snapshot, I'm a very visual person, as I think many folks are. But this just kind of helps lay out in different buckets what CHAP does. Obviously, that when I mentioned the access to care issues, there's casework that's done through the helpline and through the CBOs on helping folks access care. Appeals which are filed both on the external appeals, but also in negative determinations that are made with the plans, and to also really try to help resolve some of these issues before they need to be escalated. Again, there's outreach and engagement that is happening all over the state to try to help get folks connected to the program, educate the public about it, about the program, and to work with local community organizations and government entities to try to link people up to the program. Community education, there are a number of programs that have reached out to CHAP, looking to find out more on how they can utilize this program to help folks that are coming through their channels. And then we also do a lot of education around what insurance coverage is. It is surprising how many folks just have no idea what their plan is, what's covered. And so we help with some of that education. And then we provide training and technical assistance on a number of topics. And this is just an example of the flyer that we, one of the collateral materials that we disseminate through some of our outreach and engagement. But it really, is really trying to help folks know that there's a place where they can go to know what their insurance rights are, to have skilled attorneys that can help them address some of the insurance denials for behavioral health care, to work on our state partner conversations around barriers that we're seeing and some of the discrimination that still exists, the lack of parity, for example, that still exists, and to really help consumers get the most out of their coverage, and for providers who are having difficulty with reimbursement. And then we also, are helping to get folks who are under or uninsured enrolled in get them health insurance. So there's lots of information and support that individuals receive who call into the CHAP helpline. Next slide, please. And just, some of our accomplishments, we've handled over 5,000 cases through the helpline, as well as the calls that have come in to my office. And we've reached over 300,000 people through outreach and engagement. We track those kinds of contacts also through a data point that comes in through the Salesforce database, so that we can really be targeted in where it is that we need to go to get the word out, what populations have not yet been connected with, and how we can be strategic about that. Next slide, please. Some of the success stories that I thought might be helpful to share with the group. And just so that folks know, all of the names of folks in these stories have been changed. We want to be very sensitive to confidentiality. But Ted's story involved a provider who had contacted us to find inpatient alcohol use disorder treatment for her patient, who's Ted, who was also living with schizophrenia. As many of you know, the co-occurring nature of substance use and mental health can sometimes make it very challenging to get folks into care quickly because of the structure of programs and staffing issues. But CHAP reached out to Ted's local hospital, which did confirm that it accepted his Medicare and Medicaid. Oftentimes, some of the challenges around Medicare are that when individuals need substance use care, they can't get that care unless it is in a hospital setting, and that to access inpatient treatment following his hospital stay, which he would need to present to the emergency room for stabilization, that he needed to get transferred to an inpatient treatment program. He went to the emergency room, and they told him that initially that they couldn't detox him there, and that they could not transfer him to their detox facility because there were no available beds. We've seen a number of these cases, during COVID and post lockdown, because of some of the challenges around trying to mitigate COVID infection. So while the CHAP team at the helpline had contacted a local addiction treatment center, they were unsuccessful at doing that. They had reached out to me for help, and I was able to gain admission for Ted, do an assessment, and get him admitted to an ATC. We also utilized the expertise of Medicare Rights Center to assist with the case, as it was a complex insurance issue around his Medicare. Next slide, please. In another case, a woman whose name has been changed to Felicia had contacted us because her Medicaid managed care plan was denying a formulary exception for her medication, which was Zepsolv. And she had switched her plan a month earlier so that she could see her primary care physician. The provider had filed an expedited appeal of the plan, of their formulary exception, but initially the plan had upheld its denial. And I want to say here that oftentimes, there are lots of reasons why plans, will uphold the denial. In some cases, we're able to work with the plan to do a single case agreement, or to try to connect and get the right conversations happening between the provider or the client and the plan. In this case, we were able to switch her back to the previous plan and connect her with an outpatient program that was able to bridge her medication until that plan switch became effective and her medication was covered by her insurance. Next slide, please. In another story, in 2018, a woman who we'll call Rosie had health coverage through Medicaid and had received outpatient treatment, substance use treatment through a facility that had assured her that they accepted Medicaid. However, after completing treatment, Rosie had learned that, in fact, the facility did not accept Medicaid, and she was billed, surprisingly, for over $8,000 for her treatment. Rosie contacted us for help, and the attorneys at CHAP were able to negotiate with the facility to have her bill reduced to $2,500. Our attorneys then were able to apply to New York Times Neediest Fund to assist Rosie with the remaining balance. And that fund awarded her that $2,500 grant. And as a result of the ability for CHAP to do that debt negotiation, and with gratitude for the New York Times Neediest Fund, her entire bill was resolved, and she did not need to pay any out-of-pocket costs for her treatment. This story, I think, is really important because it also highlights, when folks are in crisis and, need care, if they're faced with costs that are beyond what they're able to pay for, oftentimes that prohibits them from pursuing care, and that can have very, very dire consequences. Next slide, please. So just to sort of talk a little bit about some of the administrative capacity of CHAP, I mentioned a little while ago that we believe very much in the importance of data. And so we do monthly, quarterly, and annual reports that we submit to the Office of Addiction Services and Supports, as well as OMH, which is the Office of Mental Health, that reports that aggregates that data that we pull from Salesforce. And we use the case examples that I highlighted just a few moments ago to really provide the context. Oftentimes, and I work in government, and I know that, we can get so caught up in the numbers and the data, but to be able to sort of contextualize this data and make it human for folks in government to really be able to understand these barriers in a way that impact people's lives has been extremely beneficial and very powerful. And it also, we also track within Salesforce what we call Sentinel Issues. These are systemic trends that we're seeing that are showing up in the cases. We identify those, bring those to the attention of our state partners in these reports, in the hopes that on a macro level, there can be, and there have been, quite frankly, some very robust and meaningful conversations that are happening that are helping to guide our government partners in how to address some of these systemic issues. And Separately, we also, have a substantial contract and budget and invoices that need to be processed. And so those happen every month. We track the deliverables to ensure that performance measures are being met. And each of the specialists and CBOs submit those invoices which are processed, and then we pay those folks accordingly. Next slide, please. I mentioned that we also have monthly training meetings for all of the helpline staff, the specialists and CBOs, and with OASIS and OMH, we do regular case reviews in which that's part of our quality assurance, but also provide opportunities for the folks that are doing the work to bring challenges to the table and provide a team approach to looking at those case reviews and strategizing. All of our specialists provide monthly policy updates that are then also submitted to our state partners and then do trainings. Once a year for 2 days, we have an intensive training. Initially it was done in person. Of course, post-COVID, it's done virtually. But all of the specialists and as well as OASIS and OMH come to the table and really identify training opportunities to help onboard new staff, as well as address issues for the seasoned team. As I mentioned, we do ongoing learning through quality assurance, and that technical assistance that LAC and the council and Medicare Rights Center provide has been very beneficial in some of the cases that have come through. And again, for that quality assurance, we plan, I don't know if I mentioned, our budget has been doubled. So we are really looking at ways to harness quality assurance and ensure that the cases are getting the attention that they need in terms of feedback for staff if there are issues, and that especially in the data world, that we're having accurate data that's being entered into Salesforce. And then again, providing that oversight and feedback and case reviews. Next slide, please. I've mentioned, a little bit about the technical assistance so that you understand sort of the nuts and bolts of that. Oftentimes, those requests will be made by the community-based organizations who will contact either CSS executive staff or the specialists for assistance with some of the complex cases that come to them. Some of those examples might be researching whether an insurance plan is subject to parity laws, or asking whether secondary Medicaid can pay for services that Medicare excludes, such as residential substance use treatment in a non-hospital setting. And also in seeking assistance for providing individuals who are in crisis who contact the helpline access to treatment. CSS and specialists and CBOs also work very closely with me and on many of these issues, and I provide that general oversight. And then, as I mentioned, some of those trainings topics include commercial insurance. As we know, there's still, differences between, accessing benefits through commercial insurance than there are, for example, Medicare or Medicaid. There's complexities around Medicare. We talk about what parity is and isn't. We talk about how to file appeals. And we also are very sensitive to confidentiality and tips and tricks to case handling, as well as working with high-risk individuals who call the helpline. Next slide, please. And just a sort of a snapshot on some of the outreach. Our specialists are conducting statewide outreach that includes tabling at conferences. We just had a big presentation, a big presence, at the New York State Fair in Syracuse. But there's also lots of other opportunities in which our specialists engage with organizations that serve communities with mental health and substance use needs, as well as sharing information through social media and other channels. And then the CBOs do a lot of local outreach in their communities. They visit hospitals, they engage with the local recovery community organizations. They show up at local food pantries, because again, those social determinants of health are all part of the complex web of challenges that individuals with substance use and mental health face. Getting the word out to mobile treatment vans, they do billboards, they take out newspaper ads, among a few. Next slide, please. So I think I tried, I know Van had tasked me with the challenge of keeping it short to really give you all the opportunity to ask questions. So I'm going to turn it back over to you.
Hey, Stephanie, real quick, do you mind going over specifically where you are in the state in terms of structure? Because I'm not sure that was clear. And also another question is, do you have a dedicated funding source?
Yes. So when you say where I am, is that Stephanie?
Well, I meant
where the program is.
Where I know that the program is a conjunction between two state programs. So if you could just sort of explain that.
Sort of the overview. So,
yep.
So the New York State Ombudsman office is housed at OASAS. I have an office there. I work in consultation with the Office of Mental Health, which is also in Albany. Have a very close, weekly conversations with them, talking about some of, the parity work that we're doing, utilizing some of the CHAP data, giving those reports and having those conversations. So we're established in the state agency, and it is funded through the executive budget, legislative budget. So we have now $3 million that has been appropriated to CHAP for the purpose of carrying out the objectives, the mission, vision of the program. I hope that helps.
Yes, I think so. And so what I'd like to do is open it up to the panel to see if anyone has any questions. Delegate Cullison.
Thank you, Van. Thank you, Stephanie, for that really comprehensive overview. I really appreciate it. And Van, you asked a couple of my questions already. But one question I have is, I know that some attorney services are provided through Legal Action Center. Do you have any attorneys within your office? I heard you at one point say our attorneys, and it's like, okay, and then so if you have those attorneys, when you go into these difficult, when it actually gets into court, what does your attorney do? Your attorneys take that into court? Are those cases?
Thank you so much, Delegate is it Callison? Yes. Thank you.
Thanks.
For the question. So the value of the way in which this program was set up is that Legal Action Center has attorneys. CSS has attorneys. These attorneys are, are specialized in healthcare navigation, as well as rights to individuals in these areas. But I also am housed. My office is at OASAS on Western Avenue on the 5th floor, which is in counsel's office. So I have at my disposal an army of attorneys that I can connect with and work with on some of the challenges that we all, some of the challenges come in. We are also contacted around patient advocacy issues, which is not my domain, but because of where I'm at and because of the relationships that I have, I can connect folks to patient advocacy at OASIS to resolve issues for individuals that contact us about that.
Thank you. And I just have one kind of follow-up. And the connections that you have outside of your office are all done contractually, right? Or through subcontracting? Okay,
Yes.
great. Thank you very much.
You're very welcome.
Commissioner Brain?
Thanks. I just had a couple. Again, thank you, Ms. Campbell, for coming in for your presentation. Really appreciated it. And we had the opportunity to talk to Elizabeth yesterday at the NAIC for our SCORI workstream for meeting on health equity issues. So that was very, very helpful as well. So really glad to spend a lot of time with the program this week. I just had a couple of what I think are clarifying questions. So if I understand it correctly, your organization, CHAP, sits within and is really two state agencies that work together and engage you as the director to oversee the program. Is that right?
Yeah, it's an interesting setup, right? Because I'm housed in OASIS. The funding.
I'm sorry. What is that again?
Office. Yes, I'm so sorry. I know we speak in acronyms so much. It's the Office of Addiction Services and Supports. So, so OASIS sort of, oversees all of the licensed substance use programs in New York State, as well as is responsible for, working with other government entities to address some of the challenges that folks with substance use face. So I'm housed at OASIS, but I am actually paid by OMH because they have a larger budget. And we really wanted to, when this program was set up, to dedicate the initial $1.5 million that was appropriated through the executive budget and the legislature to get this program started. We are now in our 5th year. It's a 5-year contract. It is almost unprecedented that a program has its budget doubled within the first contract, So it speaks to the incredible team that I work with, and the value that this program has brought people, consumers in New York State and providers. But the idea was that we wanted to really bring the behavioral health, since each of these are single state agencies. In some states, mental health and substance use are under the same umbrella. In New York State, obviously, OASIS is a single state agency, as is OMH for mental health and for substance use. So we designed it so that it would be, in consultation. All of the communication that I share with our state partners, I bring in both, OASIS and OMH, and then when appropriate, also the Department of Financial Services and Department of Health on some of the policy conversations that we have.
No, that's helpful. I mean, the program's obviously very valuable. My questions are really very technical in nature and that deal with structure and accountability and where you sit literally in state government, because beyond the program value and what it does, part of our exploration here is how it ought to be structured and where it ought to sit. So it's useful to understand how New York has done that, so that as we think about the program, it's helpful to us. The other question that I had, I have two more. The first one of two is how you interface with existing programs within the state. So for example, my counterparts at DAS will work with consumers on appeals and grievances, et cetera. So if you could sort of speak to, the Office of the Attorney General here has an health education and advocacy unit that works with consumers today with certain of their appeals and grievances, whether it's for state regulated insurance or not. And so I'm not sure, what their counterparts in New York do. I'm not as familiar with that, but I'm interested in how you harness or utilize existing resources and then how you supplement them.
Mhm. Yeah, no, that's a great question. So, so the data, as I mentioned, we're very data driven in terms of having those conversations with our state partners, harnessing the expertise that exists within the project when appropriate to bring our specialists into some of the conversations that we're having with DFS, Department of Financial Services, DOH. And then in terms of resolving some of these challenges, the Sentinel issues, the trends that we're identifying, we're having regular conversations in which we bring these cases into the conversation and try to help inform those state partners on the more micro level. On the micro level, I mentioned that we have a team of attorneys that can help clients file complaints and appeals. So, for example, if a consumer receives a negative determination for the claim that they filed, our attorneys can help that person walk through the process of filing that appeal. On the Medicaid side, on the state Medicaid contract, all of that goes through the Department of Health when that person has Medicaid, and a complaint can be filed. And also our attorneys can help, at hearings, for example, if they need to go to a hearing, helping them prepare for that hearing. Internally, we're having conversations based, as I mentioned, on some of these cases. For example, we're working with DFS in looking at the external appeals database, in which comparisons between rates of overturn on claims, on appeals for substance use and mental health are being compared to with what's happening on the med-surg side. And that analysis was, was initiated by CSS. Elizabeth and Carla did a phenomenal job at starting that. And then my team looked at this data as well. We are having regular conversations now with DFS and DOH on some of the findings. And we've got now a survey that will be going out to some of the plans to measure whether or not there are these differences. So it's a multi-pronged approach, in a macro space. When someone needs help and they contact us, we're able to help that person navigate through the process. On a macro level, what comes in through CHAP is now informing, a lot of this used to be anecdotal or sort of, happening in these sort of separate data spheres. The challenge is, of course, having interagency conversations that can be beneficial in addressing some of these issues with not just anecdotal information, but with real, time data that's coming through. So it's been incredibly effective, I think.
Yeah, I mean, it sounds like there's a tremendous amount of value for the state ombudsman to be this place where all this stuff intersects and you're able to get all the data so that you can, effectively analyze it and share it with, your fellow state agencies. That again, I'm not a policymaker here, but that makes a certain amount of sense to me. But when we're talking more specifically about the day-to-day, so I'm the person in need who comes to the program. So putting aside that macro, sort of policy-driven piece of it, but I'm the person who comes because I need help. It sounds as though when you look at how you're interfacing with state agencies, I mean, you're obviously doing upfront work to try to navigate and negotiate with whoever the provider is and whoever the payer is upfront. And then if there comes a time when you can't get that resolved, and you need to move into a more formal process, what I'm hearing you say is that at that point in time, your primary role is helping that individual navigate whatever administrative options are available to them, and that you utilize your in-house attorneys for that. And those in-house attorneys have access to specialists and really subject matter experts like the Legal Action Center to help them put that work together and with that individual who needs to file that appeal. I also, if I understand it correctly, you're not representing people in court. You're not filing litigation, that you would refer them elsewhere for litigation.
Correct.
And so the work is mostly advisory work and putting complaints together and helping them, sort of what I think our HEAU unit does in some respects. And you're not familiar with them, so they can speak for themselves, but it sounds as though that's that advisory, helping people prepare function. Those are my questions. So thank you. I really appreciate the clarification, because obviously, as nitpicky as it may be, that, you know, like as a lawyer, we're just trying to help nitpick the structure so that we can understand how things work together.
Yeah, I don't think your questions are nitpicky at all. I think they're intelligent, quantitative questions that you would want to have, you know, that answering would help, you know, create the structure and function of a program that works, you know, in Maryland, right?
And it sounds like you guys recently had an enlargement of your scope as well. Like, did you start out primarily focused on insurance and then expand into other programs? Is that correct?
Well, what we set out to do was to help people access their insurance benefits. Because of the complexities that come with the disparity that happens between the way in which behavioral health and you know, med-surg health is treated. There are also social determinant of health needs that make it even more complex. Getting someone the transportation who doesn't have, you know, access to timely transportation into a program when they're in the midst of having, you know, in withdrawal, facing the kinds of restrictions around access that happen because of COVID, and the way in which, you know, treatment centers had to restrict the number of people that they could take, or hospitals, you know, were unable to, you know, close down in-hospital programs, or programs that were really getting started in emergency departments to help treat folks in withdrawal from opioid use disorder. Much of that, you know, we were making incredible progress before COVID. And then, of course, COVID just collapsed so many of the supports that existed. So we became sort of the, you know, the place where lots of folks would contact us because they were in crisis and they didn't know where to go. And we were able to help facilitate that some of those folks' needs.
Thank you for that. Ansi got has waited a long time. Her hand's been up for a long time, so I'm going to go to Ann next.
Thank you, Van. I appreciate that. I have, I think, some quick discrete questions on the data. So since 2018, you've served 5,000 people. And I guess I'm just trying, because with the Venn diagram, we've got you, and then you've got your CBOs and your specialists. Are the 5,000 really those who just come in through, you know, the CHAP helpline, or and so of those 5,000, some have also received services from the specialists or from the CBOs, and I just assume that they also make referrals. So is it just like through that helpline that you're counting people, and then when you are collecting data, do you collect all that rest of that data? What other services they get if you do engage with a specialist or a CBO?
Yeah, so that's great in terms of the data collection. What happens? These are the you know, over 5,000 cases that we have Those have come in through the helpline, but also the CBOs are feeding into the Salesforce. So it's a collection of cases that are coming in through the helpline and also being fed through, that data is being collected from the community-based organizations. As for the cases that I get, that's a separate, because again, my salary is being paid through OMH. I'm being paid to oversee the program. What has happened because of the relationships that I have with providers and word has gotten out outside of CHAP in community, folks will contact me. Also, if a call comes in through the helpline and it's a complex case in which there's a number of different barriers that our case handlers on CHAMP are having, they will contact me to see if I can support, getting that person access to care. And there's a number of those cases that don't come in necessarily through the helpline, but again, through word of mouth, I will be contacted and I will help navigate. The cases that are separate and apart from the data that's being collected into Salesforce, are about 2,000 cases from the onset on mine. But I don't include that in this data because it's not being collected through the CHAMP, helpline and the CBOs. Does that make sense?
Just why though? Why are they different services? Those 2,000 cases?
Yeah. So the cases that I get contacted about, again, some of those cases have come through the helpline, and then I get contacted because there's a number of barriers. Some of those folks contact me in community because they know who I am, and they know that they might have some success in getting, whoever it is that needs to get access to care in quickly. That's not entered into Salesforce because it's not coming through the helpline or the CBOs, which are who are being paid under this contract. I am a government person who's been hired to oversee this project. So for clarity of data and reliability and validity of the data that's being collected on CHAMP, we've kept that separate.
But you keep that data?
Yes.
Different. Okay. That's all for now. I know we're probably getting short on time.
Thank you, Ann. I'll go to Ellen Weber next.
Thanks very much, Van. And Stephanie, thank you very much for your kind words. I really do appreciate that. I just had two questions. One, because I wanted to get a better make sure folks get a better sense of the value of the CBOs and the fact that they are in the communities. Could you speak to that just a little bit in order to really explain why in the development of this program, both CSS and obviously you thought that was an important part?
Yes, no, that's a great question, Ellen. So the hub and spokes model is, as I mentioned in that visual, there's the helpline that is a statewide helpline. There's the specialists that are feeding technical assistance and training, the intellectual arm, if you will, and policy arm, and some of these complex policy issues that come up with some of these cases. But the CBOs are really the nuts and bolts of what's happening on the ground in communities. And these CBOs are community-based organizations that are already have relationships with individuals, in community. They're trusted by the community. They have relationships with, different other community-based organizations that can help support those local CBOs being the trusted partner in that community to help support individuals who are in need. And so, it's an organic kind of relationship building that exists because, as we know, And of course, the elephant in the room, right, is that stigma is still very pervasive. And people are often afraid to come forward. They don't know if they're going to be criminalized if they ask for help. They don't know if they're going to have doors shut in their face or if they're going to be treated without dignity. And unfortunately, we're still, wrestling with addressing that both from a policy perspective, but also in terms of access to care. So these CBOs have trusted relationships in the communities that they're in. They provide valuable services, and they are an invaluable part of this project.
Thanks.
Can I just ask one quick question? I'm sorry. I guess I'm a little concrete. And could you just give us a visual? Because I think it's important to understand the experience that an individual has. They call an 800 number. And then what happens? What does their journey look like after that? Because obviously there are lots of areas of interface and walking with people, beyond the initial referral. I think it would be really helpful for the group to understand, like, my name's Kathleen and I call the hotline and what happens.
Okay. Depending on the issue. Hi, my name is Stephanie Campbell. Is this the right number to call? I've been trying to, get help for my daughter who is currently, using drugs, and I'm really scared that she might die. Can you help me find a program or tell me, this is my health insurance, and this, and I don't know if I was told that, I have to wait 6 months for an appointment for an in-network provider. I can't seem to get an appointment. Can you help me? Okay. Then the person on the line takes down the information, gets some demographic information, finds out what region they're in, and then what kind of insurance, Stephanie Campbell, do you have? What's your insurance plan? Let's look at what's in network for you. Oh, okay. What's in network or out of network? Or I thought I had just, I mean, it's right. So that kind of, walking that person through.
I'm sorry to interrupt, but who's doing that? The person who's on the phone who takes the intake, or is that at the CBO level? So is it at the
Well, depending on where they call. If they call the helpline number, then it's, the CSS team there that is taking the information. We've got a social worker who's full-time on the project. We've got, a couple of healthcare, navigators, attorneys on that project as well. So if it comes to the helpline, that's who takes the call. There's they hit the number 3 when they call the helpline for behavioral health. If Stephanie Campbell goes to Saving the Michaels of the World, is in Western New York, or where I am currently, if I go to Adirondack Health Institute and I call them up and I say, oh, I was at a community event and I saw you had a flyer about, like, you help people get their addiction treatment, and my daughter needs that. And so Adirondack Health Institute will open a case, and they'll enter all of the same information. They'll be able to help me because they know, right? They're in the North Country. They know what providers are available, right? Where the providers are. They have relationships with those providers. They also, can help that person if they don't understand what their insurance is. Can you help me understand? I don't know. I mean, I got this big packet on my insurance plan, but I don't know what it means. Can you tell me what's covered? How many visits do I have? What is an in-network? How do I get an in-network? Like, what if I can't get an in-network? What do I do that my daughter needs mental health, residential care, but there's nothing here in New York State that does, that is covered by my insurance. And then Adirondack Health Institute could say, oh, well, perhaps we can set up a single case agreement with a program. Let's say that, my daughter has an eating disorder and, needs to go to, a program that specializes in that's not within New York State. And I have commercial insurance, right? So there's all of that, again, the hub and spokes wheel. And if I'm AHI, if I'm Adirondack Health Institute, and this is a really complex, this is involving Medicare. And Stephanie Campbell also needs to get help for her mother, who is 65 plus, who has Medicare, and is drinking to the point where it's impacting her other medications, and she needs to get some support around her use of alcohol. We can pull in Medicare Rights Center because they have expertise on the Medicare plan that Stephanie's mother has. I hope that.
Now that's very helpful, because what you're describing is where expertise sits at the hub and then where the spokes utilize. So I don't want to take up any more of your time. I'll probably have some more schematic, type questions for you guys offline at some point, but that's helpful to try to understand where expertise sits at what level.
Are there any other questions? I don't think there are. So Stephanie, I think I'm going to try to give you back your day. You and your team, we are very appreciative. I think everyone here, I don't know that I can speak for everyone, but I can certainly speak for the MIA, and I see lots of nodding heads. Everyone is very appreciative of your team and your colleagues' team, and we thank you for your continuing efforts to help us as we navigate our way through trying to figure out something here. So thank you so much.
And we'll be back in touch, Stephanie, because we're going to ask you to present at the NAIC on this program as well. So more to come on that.
Great. Well, thank you so much for the invitation, and I look forward to continuing the conversation. Take care. Bye-bye.
Thank you. I think I'll turn it over to our MC now.
Thank you, Van. The next part of our agenda is to do some review of the bill. I'm not sure if it is helpful to share a screen with the bill, or if people prefer to bring it up on their own, because it is very hard to read a shared screen. I see Kathleen sort of nodding along. So
You don't
perhaps
have to, you know my preference, but I'm cockeyed because I've only had one eye operated on, so I'm not gonna try to drive that. Let somebody else can, because I'm gonna have it up regardless.
And I can say when someone else is sharing, I'm always the one saying, can you make it a little bigger?
And are we working off the bills introduced, or the bill as amended by the Senate?
As amended.
As amended, yes. So
I'll put it, how about, Mary, how about if I think most of us on here can do it, but I'll put a link to the bill just so people can access it.
Thank you. So I think the topic for today was going to be the structure, and hearing more about how New York is structured was tremendously helpful for this, because I know we've had some internal chats at the MIA trying to picture exactly how this works. So if we look at the proposed 134403, it states that there is a consumer health access program for mental health and addiction care fund. So we have the fund established. Well, first we have in 4402 that there is a program and the purpose of the program. and that it will be administered by the incubator entity and a hub entity. And the hub entity is selected by the incubator entity. And so I think some concerns were raised about how exactly that this will work, because it is not within a state agency. There is, however, a state fund. The purpose of the fund is to provide funding to the incubator entity, hub entity, and spoke and specialty entities to carry out the responsibilities of the program. And so I think the concerns lie in this structure in terms of tracing the money for state funding through entities that are not state agencies, or whether separate state agencies were located within existing state agencies. Am I correct in stating that? Does anyone want to speak to that issue?
Can I just ask who has that concern?
I'm not sure that anyone from DBM is on now. I think that we did have DBM at one point, or not. Correct me if I'm wrong, but yes, Van is frowning. But I think that was a concern because generally state funds are subject to audit requirements. And I know the MIA gets audited in various ways periodically. And it is something that is very familiar to state agencies, that you have to account for where all the money goes and what controls are in place.
Oh, and I know that the MIA has had a concern about the structure, not just part of that is a function of the accountability and the audit function that always goes along typically with how state funds are used. And this isn't set up as formally as a grant program. It's set up almost as a procurement for services, but then who oversees, that procurement. So the issue, there was that part of it, but then the other issue, at least from our perspective, the concerns that we raised were around what is it? What is the program? Can it sue? Can it be sued? Is it immune from suit because it's a state agency? Does it fall within, do the protections of state agencies apply to this program? Because it refers to a program, but doesn't really seem to be clear about a number of issues. Is there a governance board? Is the public, do PIA requests apply? So as you were thinking about how do you situate it so you know what set of legal rights and obligations attend its activities, and what the sort of how it can be interacted with, it doesn't seem to sit neatly anywhere, or at least it hasn't been clarified. And so that was one of the concerns that we raised. Van, you may be able to say that.
I was going to mention, and it ties in with what you were saying, that most programs like this will actually indicate that there is, in fact, a director who is in charge of the program, and there is in the bill there. It's not really set up that way. There is the incubator entity who, but there's no one at that entity who is specifically in charge of the program. And so that's typically what I would expect in legislation. I see Delegate Cullison's hand up, so I think I'll let her ask her question or comment.
It's more of a response, I think, I think it was Ann's question. I shared the concerns that the commissioner has raised. From my perspective as a policymaker, I'm interested in total accountability for state funds. And I think what we've learned in the first 3 meetings is that we have some of these functions happening in 3 different agencies, 3 different state agencies: MIA, MDH, and HEAU. So what I think, have come to consensus around is there needs to be coordination of much more systematic coordination of efforts. And I think that's what we're looking for. What we heard from Stephanie is that it's actually having someone inside, literally she's inside the Office of Mental Health, which is inside the Department of Health. And what I even wrote it down because she said the challenge is creating the conversations between agencies to make sure that the efforts are coordinated. And I think it's easier to do that internally than externally. An external entity will just, first of all, require a lot of infrastructure, a lot more infrastructure, and the links and accountabilities are more challenging. And there's no reason for that entity to create those conversations between our existing resources. So for me, I really, have always felt that the coordination piece is needed, but we need to make sure that we are coordinating current efforts and determining where the gaps are when we systematically coordinate those efforts. So I was one of the people who had the concern about the third party.
Thank you, Delegate Cullison. We appreciate hearing your perspective. And I think some of us have also recalled back to the MHIP days and how that was structured. And, one of the reasons MHIP was located within a state agency was so that it had access to functions like HR and procurement that the state agency could provide. So, Ellen?
Thanks very much. Again, I think there are a few points I wanted to raise just so we can bring out this broader conversation. I also found Stephanie's discussion to be very, very valuable and helpful to answer a lot of these questions. One thing to go back and ask Stephanie about, because I don't know the answers to this question, but I do know this is the case. CSS runs a number of other consumer assistance programs, and it runs them through the Department of Health. Not all of CSS's programs have the same type of dedicated full-time project manager that CHAP has. And as a result of that, they operate, again, in this same hub and spoke fashion, because all of them, any consumer assistance program that CSS develops is committed to having this hub and spoke model. So they all have that same hub and spoke model, but the level of engagement by the Department of Health differs dramatically. And again, I have tried to gather some of that information in a very minimal way. I think you can, in your additional conversations with Stephanie, could learn that also in a very systematic way. So that's one thing to be aware of. That type of internal coordination that Stephanie has strived to achieve isn't always in place for all consumer assistance programs. Now, one thing to keep in mind is that some of these other consumer assistance programs deal only with individuals who are in Medicare or individuals who are in Medicaid. What CHAP does and what our proposal does is it reflects, as Stephanie mentioned, that individuals are coming to the helpline, they're coming to the CBOs because they have multiple different types of insurance. And even within a single family, they may have various insurance problems. And so as a result of that, not only do they need the partners and the specialists to assist in resolving those problems, but as you heard, they have to talk to the Department of Financial Services about problems that arise with regard to private insurance. And so that type of coordination that Stephanie does is critically important, but it's also raised in this program, right? It's also raised in the CHAP program. We're dealing with all sorts of insurance, and therefore that raises that issue. I think the other piece that I wanted to raise is, no question, CHAP is modeled after the CHAMP program in many critical ways. We do depart in this issue that you've been raising. Is there a person within the Department of Health, within the MIA, within some other arm of Maryland government that has this kind of program manager role. But in no way, shape, or form was there ever an expectation that there would be no auditing of funds, no oversight of funds, no significant data gathering with regard to the work that's being done. That would be a given based on the level of funding that is requested to support this program. And therefore, those sets of questions, while critically important, are at least in the conception that we had, are logical questions where there's contracting requirements, there's data gathering, there's oversight, and we created a consumer advisory board with all of the state agencies on it in order to do that and monitor that and achieve that kind of cross-fertilization. So in response to Delegate Cullison's question with regard to, does an independent entity really have an interest in connecting all these other folks? Well, there's an advisory board that is in this legislation for that very specific purpose. There is nothing that this program is going to evade with regard to state oversight. And then the last thing I wanted to raise was there are other states that have independent entities that are totally independent of state government, even though they get significant state funds. And Vermont Legal Aid runs their consumer assistance program. It is done through a contract that is let by the state, and they run absolutely independently. There is no state entity that is their program manager. And in fact, one of the requirements of their contract is that they represent consumers in the annual rate setting process for marketplace plans. And so they have very distinct practices. They get state funds, though, to do all of that work. California is another example. California was started pre-ACA. They were started by a foundation. Since that time, however, they are funded by significant state funds, both marketplace funds and Medicaid funds and other funds. They operate entirely through legal services corporations, their network of California legal services corporations. So I'm happy to provide links to those programs. I know you've done an extensive review of what's out there. You probably have already looked at them. But again, there are different models, and there are independent entities that are operating with state funds with not that agency coordination or engagement that have operated for years and have operated, through audits and any number of protections.
Thank you, Ellen. Does anyone else have comments, questions, issues to raise? Delegate Cullison?
You're muted.
If somebody else raised their hand, please ask them to go before me because I'm taking a double shot here. But I want to go back to Ellen. Ellen, you brought the CHAP program based on CHAMP. We just heard how CHAMP is organized and the success it's had. Why do we need to create another infrastructure if there's a successful program that is utilizing, current resources, that has infrastructure in place, has some relationships already created? Why reinvent the wheel?
So I don't think we're reinventing the wheel, quite frankly. I think what CHAP is designed to do, it's to create that entire infrastructure that Stephanie talked about, that is the hub, the spokes, and the specialty entities. I didn't hear Stephanie in any way indicate that those functions are carried out by the Department of Health. And if you take a look at the legislation that created the New York CHAMP program, it is identified, and I'll be happy again to share this legislation. It is called an Independent Substance Use and Mental Health Ombuds Program. And it's an independent program because it's based and built off of CSS's experience and work over the years. And there's literature out there that talks about the value of having a fully independent entity. And the value of that is that that independent entity can act in ways in which a state agency unfortunately just cannot, because of its structure and its role.
Ellen, respectfully, because we don't have a lot of time left, but respectfully, while they are an independent ombudsman program, they are not independent of state government. They exist within state government. She is housed within an agency. Her salary is paid through, while dedicated funding by the state of New York through a state agency. Her legal staff are state employees. So while she's independent and she works through a hub, that is, CSS is an independent entity that is funded partially by state grants and contracts and partially by independent charitable donations. And you have CBOs and technical groups that are through contracts and receive part of that funding. She is actually housed in and paid through state agencies. I'm an independent agency, right? For a reason, but nonetheless, we are still a state agency. And I think that's what the delegate is talking about, that distinction.
Right. So if I can speak to just that question, right?
And we do have only like 2 minutes left, so keep it
and I'm
brief.
happy to take this offline. I know that we want the whole group, but bottom line is this, and this is something you should ask her a little bit about, because I got a little confused in her explanation when she was talking about in-house attorneys. The in-house attorneys that I think she was talking about are the hub, the spokes, and the specialty entity. Then go back to her, please, and clarify that, because
Van can clarify it, because we've already had that conversation with her. And we can take that offline, but
great. I think that's,
yeah.
And the independence, again, the independence exists. I'm sorry, Van.
I mean, I'll read you what the sentence says in the statute if you want. I mean, it says, there is hereby established the Office of the Independent Substance Use Disorder and Mental Health Ombudsman Program that will be operated or selected by the Office of Addiction Services and Supports in consultation with the Office of Mental Health. So it's independent, but it's within those agencies.
Again, I think my focus is, again, from the perspective of looking about how these activities get carried out. These 4,000 or 5,000 matters that have been handled since 2018. Those 4,000 or 5,000 matters have been handled by CSS along with its CBOs and its specialty entities. Those are the entities that handle those matters. And that is, again, very consistent with the framework that we have placed in CHAP. Very consistent. That same kind of data, though, and that same kind of activity is performed by Vermont Legal Aid, and the same thing that's performed by California Legal Aid in order to carry out these same functions. And again, that's why I also urge you to speak with her about how other Department of Health Consumer Assistance programs are handled by New York, because it is not that same level of engagement. So
Ellen,
different choices.
Ellen, in any of the programs that you're aware of, are any of them housed in a state school, such as this would be, where the incubator entity is the state's school, right?
Oh,
so and I will tell you, having done a look at all 50 states, I'm not aware of any other state that does it that way.
Yeah, and I can respond to that very quickly if you'd like. Clearly, because New York, well, I guess here's another way of looking at it. In Vermont, for example, when Vermont decided to set this up, they did it through an RFP, and they did it through an RFP process, and it was a process that only the Vermont Legal Aid Organization applied for. And quite frankly, when they spoke with us, they said it looked as though in drafting that, we were the only entity that could perform that activity. And there have been no other entities that have ever applied for that RFP subsequently. So in that context, there was a clear understanding that this is an organization that can do this. In Maryland, the difference is we don't have a consumer services society that has done this for ages. And therefore, we wanted to be able to have a fair process in identifying who that entity should be. And that's why we put it in an incubator entity to accomplish that.
Are you talking about the mental health law project at Vermont Legal Aid, or are you talking about the Office of the Healthcare Advocate?
No, it is Vermont. I'll put it in the link so you can take a look at what who carries this out. Okay. It is, yes. I mean, again, they do it again through contract that identifies all their contractual obligations. There is oversight, auditing, just as we've talked about, would occur in this situation in Maryland. And again, we selected University of Maryland because they work the CARES program, because they work on these kinds of issues. They get state dollars, federal dollars. They are a trusted entity. They would be a trusted recipient of state funds and one that should raise no questions in the eyes of DBM or the state legislature about their capacity to carry this out in a fiscally sound fashion. So let me put this in the chat, and I'm happy to speak with you about these other models. Van, we did the same thing as you did when we were developing this program. We talked to the states that had consumer assistance programs in order to find out and identify what their models are. And then we looked at the literature to identify what best practices are. And that's what we have, and that's why we've come up with this model.
Oh, Delegate Lewis has had to drop off for a 1 o'clock meeting. It is now after 1 o'clock. Is there anything pressing that we need to still touch on?
The only thing I'll mention is that the agenda gives us a next meeting date of October 18th, but for scheduling conflicts that have come to our attention, we're going to move it, and we'll issue a new date shortly. It'll be after October 26th.
Yes. Okay. Thank you. Okay, last call. Any comments? And thank you to everyone for attending. I know this has been a chunk of everyone's day, and we appreciate everyone's involvement. Thank you.